All right, well, let's go ahead and get started. And I want to welcome everybody that's here today. I see some friendly faces. I'm Lisa Thompson. I'm a professor at Emory School of Nursing, and I'm here to introduce Dr. Laura Ridge, who is an assistant professor at the University of Cincinnati's College of Nursing. And her research focuses on occupational health and safety, looking at healthcare workers in West Africa, particularly in Liberia and Ghana. And she's received funding from NIOSH for her pre and postdoctoral studies. And she, along with some of you on this call, were members of the ARI NCS cohort last year that was hosted at Emory. She's a nurse practitioner and in adult primary care. And she earned her doctorate from New York University. And we're really glad to have you here talking to us. And I will let you take it over.
Thank you for having me. I'm really excited to be here, and thanks to the ANHE for inviting me to give this talk. So I'd like to talk about the disposal of medical waste in West Africa, which is an environmental and occupational health challenge. As Dr. Thompson said, I am an assistant professor at the University of Cincinnati's College of Nursing, and my research focuses on occupational health among healthcare workers in West Africa. I've always focused primarily on Liberia because I've worked with an NGO that's Liberia-based called Nursing for All since 2013. And when the Ebola crisis struck in 2014, that's what galvanized me to go back for my doctoral degree. And so Liberian nurses have always really been my focus. And I'm very happy to have a Liberian nurse co-author on this talk. Shirley Fanbula is an infection prevention and control expert with over 10 years of experience. She's worked with academic consortiums, NGOs, and the Liberian Ministry of Health throughout her career. She has 2 master's degrees, and she furnished a lot of the idea and was a terrific thought partner for putting this talk together. So please consider it a co-talk, even though Shirley wasn't able to join us today. So the learning objectives for this talk are, I'd like to discuss the medical waste impacts on environmental health and summarize goals for mitigating that impact, especially in low-income countries, and consider future research objectives that might contribute to achieving these goals. To do that, I'll talk a little bit about medical waste management globally, a little bit more specifically about medical waste management in low-income countries, some very preliminary findings in Liberia. I want to emphasize these findings are not part of a study. They're just part of document review discussions with experienced nurses in Liberia, et cetera, and next steps. So medical waste management globally. So medical waste is a major source of waste. It can be produced by any healthcare facility. It's not exclusive to hospitals or outpatient offices. It's also associated with vet's office, dental practices, mortuaries. Anywhere that provides care produces medical waste. And it's on average 11 kilograms of waste per patient per day in high-income countries and 6 kilograms of waste per patient per day in low-income countries. However, medical waste has gone up precipitously in the last 30 years. Overall, our industry has a real penchant for single-use objects, and more of the equipment and items that we use to provide care are single-use. COVID also contributed to the increase of medical waste globally. In the entire world, the average for COVID-associated healthcare waste was 3.4 kilograms per person per day. So that's a significant increase over and above even the 11 kilograms. It's over 20% extra related to the pandemic. And medical waste has to be carefully managed for healthcare worker safety. Obviously, healthcare workers are people in intimate contact with this waste in many cases. We're the ones who are potentially exposed to the cytotoxic and biologic hazards associated with healthcare waste, but we're not the only stakeholders. We also have to consider the community. Community can include patients as part of the hospital or healthcare facility community, but also the communities that are out there in areas where the waste might end up for longer periods of time post-facility. So I just want to highlight those 2 groups as critical in thinking about the proper disposal of healthcare waste. So the management of healthcare waste is guided by a variety of international laws. I really wanted to highlight these two. The Basel Convention was adopted in 1992, and it was the result of some unacceptable practices that had developed as a result of sort of healthcare waste NIMBYism. So as environmental awareness had grown in relatively wealthy countries with relatively stringent regulatory frameworks, there were unfortunately practices that involved shipping healthcare waste to Eastern Europe, other developing countries, or so as they were referred to at the time, where regulations were relatively lax and financial situation wasn't as great. And as a result, the medical waste that was produced in high income countries was causing problems in low and middle income countries. And the obvious injustice of that was the impetus for the development of the Basel Convention. It took effect in 1992. It has hundreds of signatories globally. And the purpose is not to end this practice per se, but rather to ensure that it has minimal impact on the health and on the human health and the environment of countries that have taken on these hazardous wastes. The Stockholm Convention was quite a bit more recent. It took effect in 2004. It was intended to address persistent organic pollutants, or POPs. We're going to talk a lot about POPs later in the talk, but these are pollutants that are strongly associated with incineration, which is a major healthcare waste management modality. And the problem with POPs is that they cross borders. So thinking of the Stockholm Convention, a useful analogy might be thinking of a pandemic prevention policy. Obviously, one country trying to prevent a pandemic isn't going to work so well. It needs to be a product of the international community, a joint effort, especially in the context of the ability of people to cross borders, potentially infected people to cross borders. POPs can also cross borders. And so there needs to be teamwork in addressing the proliferation of this known carcinogen. So we'll talk more about them, but these are principles of waste management. So these aren't legal frameworks the way the Basel Convention and the Stockholm Convention are, but they are principles that the WHO, the World Health Organization, highlights as critical to ethical healthcare waste management. So the first one, of course, is polluter pays. That is to say that the entity that creates the waste needs to be responsible for dealing with the waste, or at the very least, compensating people appropriately for dealing with the waste. The precautionary principle. The precautionary principle basically says that you can't wait for irrefutable scientific evidence before you take action to stop irreversible or serious environmental harm when disposing of healthcare waste. So that is to say, if a certain healthcare waste management modality is likely to produce harm, you can't rely on the absence of incontrovertible data that it is causing harm to justify failing to take action. You have to act out of an abundance of caution and try to prevent the issue from developing in the first place. The duty of care is perhaps the most intuitive. It's that you have a responsibility to handle waste responsibly. Excuse me. You have to take into the needs of all stakeholders into account and handle waste in such a way as is unlikely to impact health. Sorry. Proximity. Proximity is the requirement that you handle waste as close to the source as possible in an effort to cut down on hazards associated with transit. And then last is prior informed consent, which primarily applies to communities that may be asked to live near healthcare waste. Those communities need to be appraised of the hazards associated with the healthcare waste, how they're being addressed, and so on, before the waste is planted or disposed of in that vicinity. Again, these aren't legal frameworks, these are guiding principles. The waste management hierarchy informs medical waste management as well. Avoid, reduce, reuse, repair, recycle, recover, and dispose. There are many countries in the world that are far better at avoiding and reducing and reusing, and there are many countries in the world, like typically high income countries, that are much better at the disposing element of this triangle. So we have every element to consider, and every element is key. And it guides practice everywhere, but there are noticeable differences in use and implementation. Healthcare waste is generally divided into hazardous and non-hazardous waste. 80 to 85% is non-hazardous waste. It's analogous to household waste. Think food, scraps, packaging, things like that. And then hazardous waste, chemical waste, infectious waste, including sharps. I think I read there were an estimated 16 billion injections per year. And radioactive waste. And you're going to see these 80 to 85% and 15 to 20% figures over and over again in the talk. Medical waste at the facility typically undergoes two processes. One, it's sorted by the healthcare worker. Obviously, typically the healthcare worker is the one generating the waste, that is administering the injection, administering the medication, et cetera. And that healthcare worker is often responsible for putting the waste in the appropriate receptacle, hazardous, non-hazardous. There are a variety of color coding schemes that differentiate the different types of waste. And then some medical waste management processing procedures take place at facilities that might include storage or autoclaving, things like that. Although obviously many of those also take place off-site. So post-facility, non-hazardous waste, that 80% is generally handled via standard municipal waste management. Hazardous waste might be stored or processed off-site. Storage can be under very specific conditions, especially for radioactive waste. And the idea is simply that you store it until it is no longer hazardous and can enter the general waste stream. Obviously, there are very strict engineering controls and protocols associated with that kind of storage. But there can also be things like autoclaving or incineration, landfill, other methods of disposal. Incineration is an approach we'll talk about in greater length later, but I do want to highlight that because incineration produces pollutants, the medium-term goal of the WHO is to make incineration more environmentally friendly. And the long-term goal of the WHO is to phase out incineration as a treatment approach. Now I'm going to move on to talking about healthcare waste management in low and middle income countries, but I thought this was really worth highlighting. The difference in waste produced in high income countries versus low income countries can really be astounding. The carbon footprint for one cataract operation in Wales, this was a study conducted in Cardiff, was 181.8 kilograms of carbon equivalent. So that's over 400 tons of carbon produced for one type of surgery at one area in 1 year. You can see the breakdown, 36.1% associated with building and energy use. This 10% was associated with patient travel, procurement, and then the medical equipment was accounting for the most emissions at 32.6%. This is a 2013 study that audited, again, one procedure in one city for the overall carbon footprint. But what this doesn't take into account, or what it doesn't, the contrast this particular study doesn't draw, is that there are facilities, notably in India, that can conduct a safe, effective cataract surgery with a carbon footprint of 6 kilograms rather than 181. And we know from further investigation that those facilities that are producing a tiny percentage of the carbon per surgery are seeing very, very, very similar outcome data. So high income countries, in terms of infection prevention and control, in terms of visual acuity increases, so high income countries have a lot to learn from low and middle income countries in terms of waste use and waste production. And I really wanted to highlight that before we moved on, because I think that we have to have a shift in our mentality where until now, the burden of proof was kind of on you. Why wouldn't you use that cover? Why wouldn't you use that to potentially prevent, the patient from acquiring an infection? But if we know that in other contexts, the patient is no more likely to acquire an infection, but many of these covers, shoe covers, hair covers, medical equipment covers, in lieu of like very careful sterilization, aren't being used, we're seeing the same data. It's really a much more environmentally friendly approach, and one that we would do well to emulate. So moving on to medical waste management in low-income countries, it's still a major source of waste. I want to highlight before I go on that the cutoff for high-income versus low and middle-income countries, according to the World Bank, is about $12,000 per capita. So a country where the $13,000 of GDP per capita would be considered high income. And so when I talk about low and middle income countries, I'm talking about countries where GDP per capita is less than $12,000 per year. You can see that the COVID-associated healthcare waste in low-income countries was smaller than that in high-income countries. So the 3.4 kilogram per person per day figure was global. This is a 2.5 figure for low-income countries. So we know in high-income countries, it must have been even higher than 3.4 to land on that as the average. So yet again, we're seeing a real discrepancy in the rate of use of healthcare, or the rate of generation of healthcare associated waste between the two groups. As in high-income countries, healthcare waste must be carefully managed with both worker and community safety in mind. Many low and middle income countries are signatories to the Basel and Stockholm Conventions, and I just found out what years Liberia and Ghana had signed, because those were the two countries that I had done research the most recently in. So we see very similar waste profiles in low and middle income countries. We're seeing, again, 80 to 85% of waste is the equivalent of household waste, and about 15 to 20% is the equivalent of hazardous waste, or is hazardous waste, excuse me, chemical, infectious, sharps, and radioactive waste. So very, very similar figures as you're seeing globally. Medical waste management in the facility, again, a lot of sorting takes place. That's a critical process that will take place everywhere. I do want to highlight that when hazardous waste is unintentionally sorted into non-hazardous waste, the entire receptacle becomes hazardous. So that's something for us to keep in mind. There's a lot of emphasis in the literature on training healthcare workers to sort waste appropriately. And the idea there is really sound. You want to have you want healthcare waste to be as general as possible so that municipal waste entities can take care of it. And then hazardous waste, which is the waste that costs your facility the most by weight, is the waste that costs the facility the most in terms of manpower, is kept to a minimum. I do want to highlight that that relationship is more complicated at times in low and middle income countries, because at times it is not particularly easy or relatively easy to deal with municipal waste. And so while sorting is a really important priority, the simple act of keeping general things general isn't as useful in some low and middle income countries as it is in some high income countries. I hope that makes sense. So medical waste management post facilities in low and middle income countries, it often involves landfilling, recycling, incineration, storage, as we discussed. Untreated landfill, which of course is broadly inappropriate, is a little bit more common in low and middle income countries, although obviously it happens everywhere. And these approaches are, for the record, also used in high income countries. It's just they're favored to a greater degree in low and middle income countries. Now, incineration in particular is a major means of disposal of medical waste in low and middle income countries. There was one study of over 450 facilities in Nigeria. 77% of them used burn and bury as their primary approach to medical waste management. Most of the workers at those facilities were not happy with that as an approach. They had concerns about the exposures associated with that approach. Very few of the workers had healthcare coverage that ensured that they would be protected, or that would contribute to protecting them if they experienced a negative exposure. Relatively few of the facilities, only 41%, had staffers who were trained in medical waste management. But and so the study isn't particularly optimistic, but I really liked it because it looked at so many facilities. Much of the literature on this topic is case studies where one facility is looked at in depth. And this, as I said, looked at over 300 facilities in one province in Nigeria. And so we have to keep in mind that there are lots of technical requirements associated with appropriate incineration. The incinerators are intended to be operated at a particular temperature, typically 850 degrees Celsius or hotter, but not necessarily hotter than 1100 degrees Celsius. There's special equipment that's intended to prevent the spewing of dioxin and furans, which are the persistent organic pollutants I mentioned earlier. We're going to talk more about them in more depth in the next slide, but it requires a fair amount of technical know-how to capture those chemical compounds before they can do any damage. And as a result, it requires technicians with a lot of experience and the right equipment. Typically, they're using activated carbon, which will attach the dioxins or the furans to a filter. This picture, Shirley and I chose because this was an incinerator that had been set up in Liberia post Ebola. So it was set up in Liberia 2015, 2016, and you can see it's already effectively not an incinerator anymore. Over time, it stopped working, and it was seen as more useful to the facility to use the sort of incinerator enclosure for like open burning, which is obviously a step up from open burning on the grass, which you could see might also have been an option. This will protect some of the byproducts from entering the soil and potentially groundwater. But it also is unlikely that this fire is going to reach the temperatures required for appropriate incineration. And obviously the open nature of the remnants of the facility are allowing all of this particulate matter to enter the air. So this is a new incinerator that's basically not operating as an incinerator anymore. And that happened in a very short period of time. So we thought that this picture kind of highlighted the importance of maintenance and technicians, and how quickly things can change if you don't have those available as needed. So these persistent organic pollutants that I keep bringing up, there's the two most famous of them are dioxin and furan. They are toxic substances that have similar chemical structures. They're not like produced on purpose. It's not something that we make on purpose, but they're byproducts of creations of certain chemicals like herbicides, and they're also byproducts of burning. There was one estimate that about 90% of the POPs found in Tunisia were associated with the incineration of healthcare waste. So this is a huge contributor to that issue. This is even in relatively wealthy low and middle income countries like South Africa, this is an issue. And as I discussed earlier, the POPs don't stay in one place, they travel. They can travel in water, they can travel in air. 90% of the persistent organic pollutants that humans are exposed to, we're exposed to when we eat contaminated foods. And so when you think about how diverse the settings where our food is grown are, you go into a grocery store, you see food from literally all over the world, you can understand why a multinational approach was really important in terms of controlling this pollutant that is that's really everywhere that incineration is. And we chose this picture. This incinerator is still kind of going, and relative to the other one, which you saw basically didn't exist anymore. But you can also see that this is almost certainly more particulate matter that is meant to be leaving the incinerator if it were burning hot enough, if the activated carbon were being used properly, et cetera. And you can see that that particulate matter is going to go out into the countryside and potentially expose community members. Dioxin and furans, or persistent organic pollutants, are known carcinogens. They're associated with a number of cancers, reproductive cancers, ENT cancers. There have been a variety of studies that have shown associations between exposure to dioxins and furans among workers and higher rates of cancer, but also among community members and higher rates of cancer. So keeping those two stakeholders in mind, these POPs affect both of them. So one issue that we have to consider when we're talking about the general waste versus hazardous waste issue is the virtue of general waste, the non-hazardous healthcare waste, is again that it can go to the municipal waste processing plant or facility. Whatever the municipal waste approach is, you can just send that waste off and it'll join that stream. But the problem with that is that in some low and middle income countries, municipal waste services can be privatized, or never, even if they're not privatized, rather expensive. And so the cost associated with sending general waste off might be higher than just burning it, depending on what fuel you're using, depending on how you burn it. And so we have this situation where better sorting, which is typically seen as a solution to incineration, like we're gonna sort, we're gonna get the municipal waste out of here, and then we'll just burn what's left. It actually might contribute to incineration, because we have this huge pile of trash we can't possibly afford for someone to pick it up, so we've got to burn it. So I just kind of want people to be aware of that tension, that the relative costs really can come into play, and that the answer is not always straightforward. Okay, so I'd like to talk about Liberia specifically for a little bit. So Liberia does have a national waste management policy. It was updated in 2021. The government review found the waste generated was about a half to 1 kilograms per bed per day. So as we would expect, less than you'd see in a high income country. This review was based on 3 facilities. I will say a peer-reviewed article found higher levels of waste generation. That article was also based on an audit of 3 facilities. It was older than the government policy, but it found a really markedly different result. It found that up to 7 kilograms of waste were produced in clinics per patient per day, and up to 15 kilograms of waste were produced in hospitals per patient per day. Again, both of these studies were based on 3 facilities, so neither of them is really super conclusive, but it was interesting to see the discrepancy between the two, which was pretty large. Medical waste in Liberia, these numbers should look really familiar by now. We've got 80% general waste, but then 20% hazardous waste, with roughly the usual breakdown: infectious, sharps, chemical, and special. The government policy took the trouble of adding up the infectious and the sharps to get an amount per bed per day. So you can see it's a relatively small percentage, but not as quite as small as you'd think. So just but just very, very similar to what we see globally. So you'll see this is a photograph I took when I was doing my dissertation. I'm not sure if I can like zoom in. Ooh, whoops. I was hoping I could zoom in for you, because the signs here list out, this is infectious waste. You have to think about catheters, swabs, things like that is going in this bin down here. It's the one with the lid. And then here's general waste and plastic bottles, medication packets. That's what goes to general waste. It's down here. It's a pretty good system, as you can see, clearly labeled. It's in the hallway where all the healthcare workers can access it easily. And I took this picture at one facility of the 12 that I worked with for my dissertation, but so this isn't particular to this facility, but the national waste policy in Liberia highlights that while a lot of sorting is happening inside the healthcare facility, frequently these like differentiated streams of waste are kind of smushed together once it's time to actually dispose of the waste, per the earlier discussion about municipal waste versus just incineration or open burning. A lot of healthcare facilities, in lieu of paying for waste pickup, are opting just to kind of bring these streams together and dispose of them as one. Even though there's good sorting going on, it's not actually leading to what it's meant to lead to. So medical waste post facility, as I've sort of hammered home at this point, there's a big municipal waste problem in Monrovia. Monrovia is the capital of Liberia. It's home to about 1.3 of Liberia's 5 million people. Liberia is one of the many countries in sub-Saharan Africa and worldwide that's undergoing really rapid urbanization, and it's just overwhelmed the system. And as a result, there are very, very few places for the municipal waste systems that do exist to safely get rid of trash. So you see a lot of open dumping by individuals who have no other choice. There's nothing else for them to do. And a lot of highly polluted areas. I don't know if you can quite make this out, but this is actually a pharmacy back here. And so this is very close to effectively a healthcare facility, because pharmacists often act as part of the healthcare team in Liberia. And there's very little that can be done about it. This was a picture from Reuters. The title of the article was called "Our Hands Are Tied," and it was just about the tremendous challenges that Liberia has been facing recently. The pictures from 2022 with regards to this exact issue. And there's just no easy answers. It's really, really challenging for everyone involved, and it's a huge health and safety issue. Incineration is relied upon in Liberia formally, but not operational. And I don't think this will be a big surprise based on what you saw in the pictures earlier. There's highly limited training for operators. The international incinerator standards that I sort of went through very quickly were unmet. There are other standards associated with proper incinerator use. They're intended to be pollution control devices on incinerators. Incinerators are meant to sort of be like revved up once a day, used once, and then shut down, as opposed to like revved up and shut down and revved up and shut down. That has to do with making sure they get hot enough for things to be fully burned. That obviously relies on reliable and sufficient quantities of fuel, which isn't always an option. Sometimes they just have to use smaller fires. And as a result, there's a great deal of open burning. And you can see this picture was taken behind a healthcare facility. A lot of the waste associated with the healthcare facility, it looks like general waste, and it looks like it has not completely burned. And so this is a very unsafe thing that's kind of out in the open because there really aren't good alternatives. So thinking about research, I think a good next step for us in high-income countries is to interrogate how badly we really need to use the many single-use things that we use to prevent infection in healthcare facilities. As I said, I really think we need to sort of revamp our thinking and say, prove to me why this matters versus just throw it on there and prove to me why it shouldn't be there. The burden of proof has to be on using a single-use item versus not using a single-use item. And I think that in that way, low and middle income countries have a lot to teach high income countries, because they're using far fewer single-use plastics and obtaining the same clinical and infection prevention and control outcomes. I do think there's an opportunity to do some really great case studies of rapidly urbanizing cities or countries that are not facing challenges in municipal waste, especially if those countries happen to be on the low income end of the spectrum as opposed to the middle income end of the spectrum. I think there might be some best practices out there that other countries would benefit to learn from. And then, of course, We have to know better how to train incinerator operators and maintenance people so that these incinerators that are established 10 years later aren't effectively pits for open burning. I think there's also probably an opportunity for us to research what happened to the people who were trained at the time back in 2014 and 15. Were they offered better jobs somewhere else? Were the materials that they needed unavailable so they effectively couldn't do their jobs? Why didn't some of these projects work out? There was enormous political will at the time and a great deal of money being invested in the three countries most affected by Ebola. That was Liberia, Guinea, and Sierra Leone. But some of the projects really seem to have very quickly sort of fallen apart. And I think it could be an interesting opportunity to understand how to do things better going forward. And then I think you have to bring the spirit of harm reduction to this. Best practices associated with open burning. Are there ways that it can be less harmful to the environment, less harmful to the workers who are charged with doing it, potentially through the use of PPE, less harmful to the community members who are likely to be exposed to the particulate matter associated with the burning, as well as the incompletely burned items? There are absolutely cases of children hurting themselves on needles that have not been totally burned. And we obviously don't want anything like that to ever happen. So how can the open burning procedures do a better job actually burning things? Although it's difficult to imagine they'll ever get as hot as they really need to be. Putting together this talk, I used this resource that I really wanted to call everyone's attention to because it was really fantastic. The WHO has these training modules in healthcare waste management. It's not a lot of peer-reviewed literature, but it's a lot of nuts and bolts. So when I was trying to learn, like, what is good incineration? Like, what does that look like? What are the procedures associated with it? These modules were really incredibly helpful. Every module is basically a PowerPoint. Some of them are quite long, some of them are very short, but it's very, very interesting to go through them at your own pace when you have time. And so insofar as this is an audience that's interested in the topic of medical waste management, I really can't recommend this resource enough. And then to summarize, medical waste management is medical waste is a major contributor to pollution globally. High-income countries produce far more waste than low-income countries. Some of it is very likely unnecessary and does not contribute to improved patient outcomes. And low-income countries have system-wide issues processing waste that extend to both the general/non-hazardous streams and the hazardous streams. So thank you very much for your time and attention. I don't know if there are any questions or I can stop my screen share. Can go from here.
Thank you. Thank you, Laura. If anybody has any questions, to put them in the chat or turn on your screen and ask the question out loud. I did put the link in the chat for the CE and the evaluation. So make sure that you go over there and hit that button there. Well, it's overwhelming, I'm sure. And I think you and I have talked about this, like, what are the solutions to this massive global problem that is of interest to me, because I look at the burning of plastic waste and household fires because of this plastic problem that we have. But on, hospital waste is not just plastic. Like you said, it's radioactive waste, it's sharps waste, it's chemicals that can leach into the soil. I was wondering, the incinerator in Liberia that you showed that was like a burn pit, and then you showed another one that kind of looked like it maybe was in a closed box. Is that also in Liberia? And
yeah, sorry, all the three pictures that I showed towards the end of the talk, two were when I was just sort of introducing the issues with incineration. Those were both in Liberia, and then the third one where it was just like the incomplete, almost looked like plastic bottles that were burned on the ground, that was also Liberia.
Okay. And do you think that it's maybe like I think in terms of the way low-income countries are supported by high-income countries, is there's some kind of infectious problem that, we're worried for them, but also worried for us. And so a lot of money gets poured into the short-term solutions, but then the problem goes away. And so they're kind of, the incinerator decays, like when those were built and you said that people were trained, but like, what was the ongoing training, or what happened with those people? Like, did they just revert back to what they were already doing because they basically ran out of money and kind of evaluation or whatever infrastructure to support it?
I suspect the latter. So they were built, at least one of them was built in part of this as part of this like academic consortium that was trying to support the Liberian healthcare system during and after Ebola. And I and Shirley worked with this group, and her impression was that they sort of built the incinerator, they provided some training, and then they were like, okay, this is all set. But there are so many more things associated with that, like the filters, the fuel, the maintenance if it breaks. Like there are so many ongoing challenges that it just wasn't sustainable. And I think that actually it would be a good topic for research to document the assumptions that are made by these very well-meaning and pretty well-resourced groups, and like where have things fallen apart, specifically in Liberia, but in other countries too, because it's not unique, as we know.
Yeah, yeah. No, I've seen that with people building stoves in different parts of the world that don't really work, and they work for a little bit and then they break, and then people are like, well, now I've got to go cook on something else because the stove broke, and those people that gave it to me are not coming back. And so, yeah, that's a problem of sustainability. Uh, the other kind of thought I had was, and I do agree, we overuse stuff in our high income country without even a thought, like the tray is packaged with all the things for suture removal, and we use one thing and throw the rest away. And instead of autoclaving or, using one tool at a time as we need it, which I think is what happens in low income countries, is they probably do more autoclaving, and they don't have these like steri packs that we have in the US in the hospital, or do they?
I mean, autoclaving is a pretty commonly used. There's also like steam cleaning, I think, is used fairly often for instrument sterilization, but no, like single-use instruments. I can't speak to other countries, but in Liberia, it's pretty much unheard of because it's not easy to get the instruments. And so you really can't only use them once, because then you just wouldn't be able to keep providing care.
Yeah, yeah, it's kind of like a fine line, because I remember in you know, going to Guatemala, and they would say, well, this healthcare facility is going to get 3 boxes of gloves a month. So, you're going to be reusing those gloves over and over and washing them and hanging them up to dry to reuse them later. And that's one extreme. And then the other is, we put 3 pairs of gloves on and just keep taking them off as we do our different procedures, and lots of probably overuse of gloves when we don't need them. And so, especially since COVID, but I think it'd be hard to know like what's the right amount that
Yeah.
prevents infection, but is not, the right amount, I guess, is what
Yeah, I think it's an area that's really ripe for research. I mean, at least one clinic that I saw profiled in a talk, also a cataract surgery clinic in India, they had multiple patients in the OR at the same time because they wanted to perform as many surgeries as possible. So they wanted to keep the worker ergonomics efficient. So they would just work on one patient, switch, work on another patient, go around, you know what I mean? Like it was a highly choreographed situation. And I think we would have some IPC concerns about that approach. But their infection rates were lower than the American healthcare facility. Yeah, this was a researcher who compared it to American health facilities, and they were better. they were getting better IPC outcomes and better comparable like clinical outcomes, like the improvement in visual acuity. So it was really, really interesting. And I remember the presenter had photographs, and in some of the photographs, you could see that some of the healthcare workers, I don't know if the actual surgeon, but perhaps some of the assistants, were wearing flip-flops.
Oh, yeah.
And like you wouldn't see that in the United States, but tell me why it's wrong if it's not causing a problem with infection rates.
Yeah. Well, I mean, I was in Tamil Nadu in India. We were in a postpartum unit, and well, it was a hospital actually. So we were going into the whole hospital, and the steps outside into the hospital, you take your shoes off and you walk into the hospital barefoot. And that's a procedure to keep the hospital clean, right? Because we're not tracking dirt into the hospital. And everywhere there's women just sweeping and mopping and sweeping and mopping. And I kept thinking, okay, so far so good. But then, you know, you get into the postpartum ward and there's women, you know, who are bleeding. And so you're like, whoa, I don't want to, like, I'm not sure about this floor anymore, because, you know, you know, there's body fluids and stuff. And so it was very interesting to me to see the way low income countries have decided to do infection control however they could. And that's if you're gonna have a lot of people coming into the hospital, they need to take their shoes off, clean their feet, and then walk in. And, but then you have to assume that the floors are clean in the hospital. So I've never seen anything like that or experienced that, but
Yeah.
they do. So the flip-flop sounds kind of on par with, except in this place, they were leaving their flip-flops outside the door.
Yeah. I just think we have to kind of give up this more is more mentality in high income countries when it comes to using single use items, because it's contributing to a huge environmental issue.
Yeah.
And I think that, you know, you don't have to go with less is more, but you have to figure out the happy medium.
Yeah, I know. I mean, I was at a talk at Sigma in San Antonio in November, and the president of Sigma was, you know, because their vision now is of sustainability. They have one of their platform aims is sustainability, and he talked about climate change. I was like, oh, this is great, you know. And he said that, you know, he said, why can't we go back to that autoclave in the basement? And I immediately like thought, oh God, I remember when I was a volunteer in the emergency room before I was a nurse, and one of my things was to take the cart and roll it down to the basement to the autoclave so that they could clean the instruments, so that I could take them back up. And this is like, you know, 1988. It wasn't, we're not talking like the dinosaur era. But now I don't even know if that is still done in hospitals, or whether we just relying on the prepackaged plastic packs with all the plastic stuff. And the same with the clothing. You know, we used to wear gowns and have sheets, and now we have plastic sheets and plastic gowns, and you know, everything just gets thrown away. Everything is single use. And so we have a lot to do in this country because of the volume. And then we have a lot in another country where they don't have municipal waste to deal with the small volume that they have to burn or dump because they don't have a way to dispose of it properly. So it's things we don't see here because they just magically disappear.
Yeah.
So it's like two different worlds, and how do we get to the place where everything works is a big challenge for you. But I'm so glad that you came and presented your work, and look forward to hearing more about interventions or things that you come up with that could offer solutions.
Yeah, thank you so much for inviting me. It was a pleasure to put the talk together and learn more about some of these topics I was not particularly well versed in, others I was more familiar with. It was great. Thank you.
Yeah, it's great. And this will be on YouTube, and we hope to invite you back. For those that are here, I saw Pam Jackson, and she will be our speaker next on the 25th of April. And she will be talking about the impact of epigenetic age acceleration on racial and neighborhood disparities and chronic musculoskeletal pain. And she's an assistant professor at the University of Alabama at Birmingham. So she'll be our speaker for April. So if there are no further questions, we can end early.
Thanks. Thanks for
Yeah.
having me. Really
Yeah,
fun.
sure. Take care, everybody. Bye-bye.